I'm going to give you a talk on acute rashes. I can't remember what this has got in it, and I don't remember on what occasion I last gave it, but let's give it a go and see what happens. Terminology in dermatology. So we use special words, and it is important to just make sure we're on the same lexicon here. Danger signs, when to call a dermatologist, and more about drugs, I think. So in terminology, we talk about primary and secondary lesions. We also need to know where they are distributed and their array. So are they in a linear array? Are they in an annular array, which means ring-shaped? That sort of thing. So the words we use are macule, which is a small flat patch, patch, which is a big patch, and those two are basically non-palpable. They're just colour change. And there's a bit of overlap. So a macule's something less than a centimetre and a patch bigger will do. Papule is palpable, but it's small. They're usually dome-shaped, and they're usually multiple. Nodule is bigger. They may be solitary, occasionally multiple. Plaque has a flat top to it, so the papule is dome-shaped, the nodule is dome-shaped, the plaque is flat. So you can have papules and plaques. Papules, nodules and plaques. A tumour is a bigger growth. A vesicle is a small blister, usually multiple. A bulla is big blisters. Pustule is purulent, so instead of being clear coloured blister, it's not transparent. They're often yellow, but they can be white and they can be green. Abscess is a bigger collection of pus. A wheal is a skin swelling, which is transient, and a cyst is fluctuant because it contains something that moves. So, here's some macules. They're brown on the left, and we got a white patch with brown macules within it on the right. We've got some papules which are elevated on the left, and some plaques which are flat-topped palpable lesions on the right. Shall we have nodule, tumour, vesicles, bulla, or bully, pustules. Now, pustules can be infectious or not. So the one on the right is due to Staphylococcus aureus, and the one on the left is not. It's just neutrophils. And really they look the same. So we need some other clues. So the one on the left is going to be cold, the one on the right might be hot, the one on the left has no fever, the one on the right might do. So if you've got blood in your bulla, it's hemorrhagic bulla. If you've got dead tissue that's gone black, that's an eschar in an area of ulceration. So if you're bleeding into the skin, there's one form of purpura, purple spots, and they don't blanch. But if they're small, they're called petechiae, and if they're large, they may be called purpura. If you can feel them, they're called palpable purpura. It's very important when you're evaluating someone with purpura. Is it palpable? Because if it's palpable, that suggests there's an inflammatory process going on, whereas if it's not palpable, it's just bleeding. Well, once you've got your rash, you might do something to your rash that makes it look different. So if it's itchy, you might scratch it. If it's infected, you might have secondary changes due to infection. So we have scale, which is keratin. We have crust, which is dried up blood. Excoriation, which is scratching. Lichenification is due to rubbing constantly, 10,000 rubs, and you'll produce lichenification, which is thickened skin that has increased skin markings. Erosion is part loss of the skin, ulcer is full loss of the skin, and a scar is fibrous tissue. So if you see a white mark following something, Maybe you had eczema and now you've got a white mark. That's not a scar, because eczema doesn't cause scarring. It's post-inflammatory hypopigmentation, not a scar. Scale. Then when you have something that's scaly, we need more description of the scale. Is it localized? Is it diffuse? Is it symmetrical? Is it bran-like? Is it large flakes? Is it just dryness, really? Can you brush it off? Crust is often a mixture of scale, but true crust is just dried up blood, serous ooze. Erosions and ulcers. Scars, fibrous tissue. Lichenification, often pigmented, but increased thickness of the skin and increased skin markings. We need to put our spots together to make a shape. So the one on the left is confluent, annular, plaque. Or it could be papules, or a bit of both. The one on the right is linear, pigmented plaque. It means you could feel it. You can't see from the picture that it was plaque, but it was. You could feel. Okay, so we already mentioned that if you have a patient who's ill, blisters and mucosal involvement, that's a danger sign and you need help. So that's not a standard referral, that is a phone call or a trip to the emergency department. So we're going to do some case histories. A patient presents with a fever and a rash. Non-specific aches and pains, papules and pustules, mainly on the trunk. What we have is some pustules with a little erythema, and from further away we can see that they have an annular configuration. So these pustules are on plaques and the rings are joining together, so they've become polycyclic. Any clues from that? Have any of you ever seen anything like this? We had one last week. Not common, right? You'd be go, ooh, right, what's going on here? Okay, so differential diagnosis. Varicella, sparple folliculitis, sea bather's eruption, Grover disease, acute generalized exanthematous pustulosis, generalized pustular psoriasis, and sweet disease. Heard of any of those? My one last week had generalized pustular psoriasis. Now she has chronic plaque psoriasis, for which she's on methotrexate. On 3 occasions that we have documented, she's presented with acute generalized pustular psoriasis. And this time she presented with a history that she'd gone to the doctor with a sore big toe, sounds like gout to me, and was prescribed Augmentin, which seems a bit odd for gout. But there you were. And on her second day of Augmentin, she burst out like that picture you've just seen. Could have been her. But I look back to the other 2 events that we had in the history, which were the last one I think was about 4 years ago. And on neither of those occasions had she had Augmentin. But I think it was the Augmentin that did it, because we know the amoxicillin group can cause this one here called acute generalized exanthematous pustulosis, which is quite close to generalized pustular psoriasis in terms of what it looks like and how it behaves. So, odd. Okay, so how are we going to tell if it's varicella? Generalized aches and pains and fever and a rash. What are the clues to varicella? Didn't hear any of that.
History of chickenpox.
Well, varicella is chickenpox.
Yeah.
Oh, you mean they've had it before? Well, you only get it once, unless you've been on rituximab, when you can get it again. My brother-in-law had a stem cell transplant, and he got chickenpox. So when you've had a stem cell transplant, they do revaccinate you, including to varicella. But it's 6 months after the transplant, and it was in that first 6 months he got varicella and was very sick from it. Yep, so you've had it before, so it's not going to be that. Yep. So there'd be vesicles as well as pustules. Yep. Itchy. Yep. Varicella's itchy. Very itchy.
All different sizes?
No. Usually they're pretty much the same. From a dermatologist's point of view, maybe subtly different. They affect inside the mouth. Varicella. Spa pool folliculitis. And 3 people can get in a spa pool, and only one gets a spa pool folliculitis. But my little history on that one is my children were teenagers. I went to pick them up from school, and the matron of the boarding house was waiting for me, and she said, "Dr. Oakley, would you mind just coming in here for a moment? We've got 3 or 4 girls have come out in this pussy rash." And they had spa pool folliculitis. The embarrassing thing was I knew that because they'd been at my house. My husband was not popular when I got home. Okay, sea bather's eruption. Generally everybody knows about it because everybody at the beach has come out in this rash. And it's usually in the shallows, and they've been lying on the sand in the shallow water. And that's from Cercaria, so it's from baby jellyfish. Grover disease, extremely common reason for us to be asked to see someone with a pustular eruption, but usually when we turn up it's not so much pustular as little crusted sores. Very, very common. Have you seen Grover disease? You've actually all seen it and ignored it. If you don't know the existence of something, you can't see it, right? So Grover disease is more common in men than women. We see it in hospitals because it's a sweat rash and lots of people in hospital are sweating. It occurs in older people, men, and the mid-trunk, and it can be symptomatic or not. So many middle to older age group men have a spotty rash on the middle of their trunk and they haven't even noticed. When you look carefully, you will see little erythematous papules, a few pustules, and some crusted sores. Transient acantholytic dermatosis is the proper name for it, but no one can ever remember that, but they seem to remember the Grover disease. So it's not so transient either. So if you have a fever and you get your Grover disease then it's transient, it'll recover. But if you've had it for 10 years, it's persistent. It can be very, very itchy and untreatable because it's relating to sweating. We have to stop the sweating to clear it up. And so we might give prednisone because it's an inflammatory skin disease, but you have to give about 40 milligrams till they get any relief. And they have to stay on 40 milligrams, so they have to be in a bad state to do that. Nothing works. So we have to use a fan, select appropriate clothing, so we get people in hospital for their relatives to bring in sweat-resistant fabrics. So it's quite hard. Acute generalized xanthematous pustulosis is a drug rash. Generalized pustular psoriasis is rare. Sweet disease. Anyone heard of sweet disease? It's also called acute neutrophilic dermatosis. And so that can happen out of the blue. They have a fever, they have aches and pains, and they have a rash, which often has pustules or pseudopustules or vesicles or pseudovesicles. That means it looks like a vesicle, but you can't get fluid out of it. So that's varicella, a relatively monomorphous eruption. Vesicles at that stage. Sometimes pustules, sometimes they're all pustules, and you can get strep complication of varicella. And the children that die from varicella, and some of them do, it's usually from the strep or a pneumonia. So scalp, face, trunk, and not really on the limbs. look inside the mouth, and you've seen a lot more than I have. And please encourage vaccination, which of course is now PHARMAC funded, thank goodness. Palpable folliculitis. The flank is a common site. You may just have a few. Again, it's monomorphous. Monomorphous means all the spots look the same. They're red papules, vesicles, and pustules. If you swab, you will grow Pseudomonas. But if you don't think of it, you will shrug your shoulders, you'll give some antibiotics, because that's what you do in general practice, and you give the wrong one and it doesn't work, but it gets better anyway, because it's just a short-lasting thing. So it occurs mostly where the swimming costume is. So this is supposed to show you somebody's got a swimming costume and it's sparing. So that's got a strap across there, so it's under the strap. Another strap there, under the strap, and on the bathing area. So that's characteristic. Sea bather's eruption, again, most prevalent where the swimming costume is. Grover disease tends to be most prevalent in the anterior sternum, epigastrium. Papules can be tiny or they can be juicy. You can have pustules, you can have crusted sores. Probably most of them look like that, actually. The crusted sore would be the most common. And yet, have I? Says the man when you say, oh, you've got a good going Grover disease there. He said, what? Where? Who? Oh, yes, I've always got those. They don't matter, do they? I say, no, they don't matter. AGEP. So an acute reaction to a drug, most commonly a penicillin antibiotic, but there are others that will do it. We would admit 1 or 2 people a year with AGEP. Acute, generalised, exanthematous pustulosis. They're ill but not very ill. They may have a history of psoriasis. So it's slightly more common in people with a history of psoriasis than people that don't. Psoriasis is a neutrophilic disorder, in part. And when it peels off very dramatically. And they get fabulous strips of skin that you can peel off. And the pustules are very, very superficial. So you can just wipe the skin and you wipe away the pustules, which is I think you can see from this here, just minor trauma wipes the pustules away. We do generally biopsy it. If you take a blood test, they ought to have a high neutrophil count, probably a bit of a raised C-reactive protein. You stop the antibiotic and it will go away. Now this disorder looks pretty similar, but this is the acute generalised pustular psoriasis where there is no drug. It just happens by itself quite suddenly, and people will have this for weeks on end, and then gradually it'll settle, and then they'll come back a year or 2 later with another flare. This particular patient has just been in hospital again. On each occasion she was prescribed systemic steroids. She has a medical alert saying, do not give this patient systemic steroids, because that's what happens if you do. She's been admitted about 6 times, each time precipitated by systemic steroids. You'd think the patient would know by now, but I gather this most recent admission, I hadn't seen her for a decade, but this most recent admission, she's now got dementia. So there was, and of course, a new doctor who wasn't aware of this disastrous occurrence with prednisone. She's not allergic as such to prednisone, but I wouldn't give it to her again. It's not a good idea. So she has a high fever, she has aches and pains all over, she's confused even when she wasn't demented, her calcium levels drop, so she has low calcium. and she's at risk of secondary bacterial infection. And in the old days, people died from this. Now we we'll show, if they'd looked in the old notes, they'd see she responds really well to acetretin, which is a retinoid. I was on leave when she was admitted, so I didn't know. Otherwise, I could have saved her a few days in hospital. They gave her methotrexate, which was also effective, but a bit slower. So the patient is ill. They need to be in hospital. That's blooming obvious. Sweet. It can be localized. So you might have your acute neutrophilic dermatosis might be just around your neck and shoulders, or it might be generalized, as in the case on the left. Patients otherwise well, sudden acute rash, feels unwell, aches and pains all over, may have some swollen joints, may have mucosal involvement, conjunctivitis, sores in the mouth. Not very ill, moderately ill, and a neutrophilia. And when you look at each plaque closely, there may be a little bit of peeling, but really it's mostly dermal, so there's not a surface component. But it looks as if there ought to be. So, it looks as if there might be a blister, like this one here. That looks like a pustule. But these look as if they might be blistering, but they're just full of neutrophils. So it's diagnosed by histology. Lots and lots of neutrophils. It's not an infection, but it can be precipitated by antibiotics and by infection. It's a reaction pattern. So it's a reaction to something else. Many of the patients have an underlying condition such as ulcerative colitis, rheumatoid arthritis, but that's probably only about 40%. The other 60% are otherwise entirely healthy. The neck is a particularly common place. So, of course, there's the infections as well. Okay, so that's that. Then we've got another acute rash. Patient comes in, she's unwell, and she's black on her area in her lower leg and says, I think I was bitten by a spider bite. And I said, did you see the spider? And she said, no, but my neighbour said this is what spider bites look like. Now, I've yet to see anybody bitten by a spider who saw the spider. Now, I saw a man recently who claimed he saw the spider, but what he described to me was not a spider bite. So ACC has hundreds of claims each year for spider bites. And yet, the entomologists tell us that's not possible. The New Zealand spiders, if they bit you, would not be resulting in an ACC claim because it's a minor problem. Black area on leg. Okay? Call a dermatologist. We tend to see them late, and no one can remember the history anymore. Fever and a black area on the leg. Neither of those were cellulitis, by the way, or spider bite. So, do you know what a vasculopathy means? Vascular, opathy, something wrong with the blood vessel. And we have occlusive vasculopathy and we have inflammatory vasculopathy. So occlusive vasculopathy means there's a clot or something, not necessarily a clot, but something blocking the blood vessel. If you don't have a blood vessel to go into your skin, there's no circulation to the skin, so the skin will die. So you get a black spot. So if you've got an occlusion of a blood vessel, you're going to get a black spot. You might have an inflammatory vasculopathy like vasculitis, which is an immune complex reaction where you have antibodies attacking, well, antibody-antigen complexes on the vessel wall. Your antigen might be Streptococcus. Group A, strep. You develop antibodies to that, so you've got an immune complex between your strep and your antibody. That immune complex lands in a vessel, blocks the vessel, inflames the vessel, and causes a palpable purpura. That can have the same effect. You've blocked the blood vessel. There's no blood supply to the skin. It goes black. Okay, so this is the one and only condition I believe was due to a spider bite. This was a 14-year-old girl. She did not see a spider. However, she was at rowing camp and they were camping, and she went into the boat shed and she put boots on in the dark. And her theory was she thinks there was something in her boot. Maybe there was, maybe there wasn't. So she presented, it was a middle of summer, public holiday. I was called. I saw this girl at my personal house. That's a picture I took at home of what I saw. A localized black blister. And the one on the left we're talking about. And I thought, I think that might be a spider bite. I've never seen one before, never seen one since, but I think it might have been. And the only spider that will do it is the redback Australian. There's a few of those in New Zealand. And the katipo. And both of those are very shy spiders. They'll run away if they see you. They live on the beach, and hardly anybody has ever seen one. The one on the right was sent to me and was a localized reaction to a spider, which apparently in Australia, which was apparently seen, and the arrow points to two little tiny dots. Apparently, if you're bitten by a spider, you're supposed to have 2 holes. And this isn't necrotic. It didn't go black. It's just a red reaction. Not serious. Patient not ill. Just a red reaction. And that's more typical. Not worth an ACC claim for. So the spider bite is generally you don't know because it's not painful. White-tailed spiders don't cause necrotic arachnoidism, so you can't get a black hole from a white-tailed spider. They look pretty evil. They're in every room. We can probably find one here if we look hard enough. And they're often blamed. They're Australian too. We blame the Australians for all sorts of things, don't we? So you should have a hole in the middle and a red ring round it. But that's not necrotic. It's just an inflammatory reaction. Erysipelas. It's the same thing as cellulitis, but it's much more superficial. And it's always group A strep, whereas cellulitis is nearly always group A strep. It can be a number of other things, especially staph. So how do we tell the difference? Well, the erysipelas is very sharply demarcated, whereas the cellulitis being deeper, there's less of a clear margin. You know, we get the pen out and we draw the edge of it. It's a bit imprecise, that drawing. We can draw it really well on the erysipelas. And the erysipelas quickly becomes necrotic, and the black spots in the erysipelas are very common. You can have both. You can have erysipelas on top of cellulitis. The one on the right is cellulitis. We've dealt with that really, but you can get blistering. This is a patient who had lipodermatosclerosis and an episode of confirmed cellulitis. Can't see it in this picture, but she actually had a lymphangitis going up to the lymph vessel, which we don't see with lipodermatosclerosis. So she had lipodermatosclerosis and cellulitis. And this is an erysipelas that's got superficial bleeding. So necrotizing fasciitis, the patient is dangerously ill. You've already sent them to hospital, not your problem. They still get missed though. And how you diagnose it is you stick a pin in it, and the patient doesn't scream. You know they've got it because it's so severe that it knocks out the nerves, and the affected area becomes numb. But if you don't remove all that necrotic skin, they are going to die. So it's an acute surgical emergency. Can be strep, can be mixed bacteria, can occur in fit, healthy people. But often they've got diabetes or some other predisposition. So you don't want to miss that one. Antibiotics are not enough. need surgical debridement.